What about this problem of sentinel headache? But some people don't believe it exists, this sort of warning leak. Do you think that's a recognised phenomenon, or any thoughts on that?
Yeah, it's controversial. It was first described in the Lancet by Raskin and Day many years ago now. I think that, again, the problem is that because not all of the sudden onset headaches are subarachnoid hemorrhage, that is a difficult area to dissect. But I think that I think irrespective of whether the person's had a so-called earlier sentinel bleed, if they come along to you with this thunderclap headache history, I think you just have to do what's proper. Time is of the essence.
Okay. Perhaps we could just pick up on another couple of potential medical emergencies. Arterial dissection, I guess that could present as a thunderclap headache.
Yes, it can.
When should we be looking out for arterial dissection? Are there any particular sort of histories or
sudden onset facial pain, typically with eyelid drooping because of the sympathetic effect of the carotid dissection. So sudden onset pain plus or minus weakness or brainstem symptoms if it involves a vertebral basilar system.
And what sort of people, certainly if you've had a bit of trauma or even seatbelt, that's said to be something to look out for? Yeah,
trauma, something to the neck. There's a lot of the exotic range of things. You know, the lady who sat in the hair washing place with the head back for too long, that sort of thing. Unfortunately, the person who's been to the chiropractor with neck pain and had a bit of a twist is another one. So, you know, if someone's had something funny happen to their neck, then thinking about dissection is a good thing. The other group of people are the tall marfanoid people who are a little bit at risk for this. So the very tall person, hypermobile joints, high arched palate, that marfanoid or Ehlers-Danlos type person is at risk for this. So that if someone walks in with the sudden onset head pain and you think they look pretty tall and bang their head on the door as they come through, dissection.
Okay. The rare one, which is we probably wouldn't see in a career, but it's important not to miss, is cerebrovenous thrombosis.
Yeah.
How does that? Can you just say a little bit about what's going on there and how does that present?
Yeah, that thrombosis of the large veins, the large venous sinuses, so the sagittal sinus or the sigmoid sinuses. It's one of the presentations to be concerned about is during pregnancy, where there's a little bit things are a bit hypercoagulable. The presentation with an onset of a seizure, onset of headache. Onset of stroke, all in a pregnant woman, should make you sit back and wonder about that. A very troublesome problem.
And how that could present in any way, really, could it? How does that?
Yeah, that's the problem, because you've got the effect as the cerebral sinuses get blocked. You get development of edema, and that can present with the range of things from headache to impaired consciousness through to seizure. So one has to have one's radar up a bit on that.
Well, hopefully we wouldn't see that in a career, but we certainly have to be on the lookout for it in the back of our mind. The one thing we probably see a little bit more often is temporal arteritis, and I guess we probably see a little bit more of that than you do in your specialist practice.
Yes.
I mean, pulsating temporal artery pain in this area is the common presentation, and we're worried about claudication and all the other sort of consequences. But can the headache present in any other way? Could it be confused for any other type of headache, do you think? Is it always unilateral, or can it be bilateral?
You know, all the cases I've seen when I was in a less rarefied atmosphere were unilateral. I've seen it misdiagnosed as cluster headache because there was ptosis, as I recall. So any sort of other facial symptomatology making someone think about another headache form. But I think that in the age group if you don't do a lot of normal ESRs, you're probably not thinking about it often enough, and there it's a cheap test.
Well, they don't do ESRs anymore now, so it's CRP. We certainly at Devon we do. So the inflammatory markers do go up, and I believe CRP is a better, more sensitive test than the ESR.
Well, you do them every day, so good. So you do that.
But unfortunately, 5% of them will be normal.
Yes.
And I don't think I've ever had to biopsy someone, but it is something that is in the textbooks. But that's always something at the back of our minds as well. And I guess if you have a high degree of clinical suspicion and the inflammatory marker is normal, then they have to get biopsied.
Yeah, you can't. And the reason for doing that is talking about something that I have managed much more commonly, is the consequences down the road. So when the diagnosis is without a biopsy, patient gets on steroids, and if there's any question around the diagnosis, then when the steroids are reduced, maybe a headache comes back, you're in a really difficult position knowing what to do. Long-term steroids are awful to manage, and having pathology to let you know that the diagnosis was bomb-proof is really helpful a year down the line when someone's skin or bones or something else is falling to bits and you're wondering whether you're going down the right road or not.
What's your strategy for steroids with these people? How long do you sort of put them on for a certain amount of time, then try and weed them off, or do you follow the markers, which are going to be probably down anyway if they're on steroids? Do you have any sort of feeling about how we should manage steroids in primary care in this condition?
Oh, I think that's really difficult because you're looking at suppressing them for a long period of time. You may be looking at adding in steroid-sparing agents. I think that it seems a bit unreasonable to expect the general practitioner to be deciding when to add a steroid-sparing immunosuppressants. I really think that's that's the sort of thing that the neurological community has to step up to the plate on.
But what would be the minimum amount of time you'd expect someone to be on steroids for with a diagnosis of temporal arteritis?
More than a year.
Would you? Right, okay,
Yes.
Yeah. Okay, thank you. Let's move on to another common area that's thought to cause headache. I suspect it probably doesn't cause that much headache, and that's hypertension. Of course, if someone comes with headache, they all think they've got their blood pressures raised, and a lot of people can say they can tell when their blood pressure's up. Clearly, for malignant hypertension, where you've got papilledema, your blood pressure's up in the sky, you're going to get headache. But do you think there is a connection between raised essential hypertension and headache? Do you think it actually causes a problem?
I don't think that it causes the problem commonly, but I'm absolutely convinced that from time to time you'll run across a patient in whom it's important. And the last one I can think of, oddly enough, was a cardiologist who, for some reason, was less interested in treating himself than he might wanted to otherwise be. So we know physicians heal ourselves. I think that it happens, but as you say, I think it's much less common than we'd like to think.
Probably far more common is actually having headache from the medications that you're using for hypertension anyway, I guess.
It's absolutely good observation. Some of them are quite unforgiving when it comes to headache.
Yeah, okay. Something that's always in the back of both the patient's mind and the practitioner's mind when someone comes with a headache, that's a space-occupying lesion. Gliomas are most common, about 70%, meningiomas about 30%, but the outcome from gliomas is not good.
No.
Having said that, only 10% of headache presentations with a tumour are due to isolated headache, all tumour presentations due to isolated headache, so the actual prevalence is quite small.
Yes.
But what sort of features, in the next video when we're looking at investigation, we'll perhaps think a little bit about red flags, but what clinical features of the headache would you be looking for in someone who presents with a tumour?
Oh, the classic features for space-occupying lesions are that the headache is worse in the morning, worse with valsalvaring, coughing, bending, straining, lifting. It can wake them at night, worse with laying flat. So it's about raised CSF pressure. Those are the sort of things that bother me.
And the headache's featureless.
Having said all of that, all of that is more common in other sorts of headaches, as you know.
Is the problem.
That is the problem.
What about other non-malignant space-occupying lesions, cysts, AV malformations? Do they present with headache, or is that sort of theoretical rather than actual practical problem?
Oh, the MR era has produced more insight into the benign than insight into tumours in comparison to CT, if you, from a practical clinical point of view. So what I mean by that is that you MR people, you find these isolated cysts, they're not doing anything particular harm, and very often the headache, there is no particular headache presentation. AVMs more or less are the same. The only particular thing about in the headache sphere for the AVMs is sometimes they will irritate cortex, and you'll see changes in migraine aura, prolonged migraine aura, that sort of thing, rather than any headache, specific headache problem.
Right. What about, let's move on to disorders of pressure if we could. We've talked about how the lining of the brain can get stretched, and clearly any space occupying lesion can cause raised intracranial pressure and give you a headache, but there is a group of patients who get a raised pressure we're not really quite sure about, idiopathic.
Yes,
can you say a little bit about that? Who should we be on the lookout for? What clinical features?
Idiopathic intracranial hypertension is typically, idiopathic intracranial hypertension is typically a condition, of females of midlife who are somewhat overweight, and their headache will have the early morning Valsalva, coughing, venting, straining, laying down feature. Classically, their headache gets better as the day goes on. Starts bad and gets better as the day goes on.
And then there's the reverse of that, the low pressure headaches, and I think a lot of us have seen them on our previous jobs doing obs and gynae with epidurals leaked, and that's sort of probably the most common cause. So anything that causes a leak in CSF, I guess, can give you a low pressure headache. Yeah, typically low pressure headache, and these all come in a little group of headaches called new daily persistent headache very often. So the patient comes along and tells you, I've started having headache, and it twigs a few things, and we're a little bit going down that road. So low pressure headaches are typically well when the person wakes up, and then gets worse as the day goes on, because that has to be brought on by posture, by being upright, and they get better if they go lay down. Right. Quickly. And what are some of the causes of low pressure headache? We've said any instrumental interventions can give it.
Yeah, over vigorous valsalvaing. So when a person's clearing their ears vigorously in the plane, lifting, weightlifters get this sort of headache. When someone's moved house and had to do a lot of lifting, it can happen with orgasm, for example. So any sort of vigorous, and then there's a group of them that are just idiopathic without, unfortunately, meaning we don't recognise any immediate onset.
It's spontaneous.
Yeah, spontaneous.
Yeah. We're not going to go to treatment, because I think the important thing for the GP is to recognise the diagnosis, and treatment is obviously a specialist care problem. So I think it's important that we recognise those two, and perhaps we could move on to something we do see probably more frequently in primary care, and that's headache due to trauma. I mean, so a lot of people with whiplash injuries, a lot of people have had a head trauma, minor head trauma, and then they come back with headache, a few weeks down the line, often associated with these other post-traumatic type syndromes. And often the headache is not commensurate with the extent of the trauma.
No.
What is going on here?
Yeah, that's a really interesting question. Among the many, it's an ill-understood problem, as you say. Anything from banging your head with the sugar bowl through to these traumas in accidents. I mean, it's not understood clearly what's going on. Some of it has to do with acceleration, deceleration injuries and changes in the long track changes it's speculated upon. I think that this is an area which is going to receive a lot of attention, because it's become a very common problem in returning war veterans. Certainly in the US, and probably, and there's no reason why it wouldn't be happening to the UK veterans, because of the helmets. People, our soldiers now are doing much better at coming back, but coming back with closed head injuries from these improvised, these so-called IED devices. So I think that it's an area that will be better studied and not very well understood, and it's a remarkable how people can have a lot of trauma and have nothing happen, and some will have very little trauma and have no reason, no want to have their headache. I mean, there's nothing litigious going on, and the headache starts. My prejudice is that group are headache prone, that is to say probably migrainous at some level, and it's that combination between that headache proneness and the trauma, which kicks the process off, but more than that is not understood.